Hello, my name is Brandy Garza. This video is an educational video about osteochondritis dissecans in the pediatric population. This video is being made as an assignment for Nursing 652 at Gonzaga University. Osteochondritis dissecans is an osteonecrosis of the layer of bone just below the cartilage or the subchondral bone. Commonly, it occurs in the knees, but it can occur in the elbow, distal humerus, and the ankle as well. And usually it's developed in the posterior lateral side of the medial femoral condyle. It is not completely understood why lesions appear and become necrotic, but it's thought to be a result of continued small stresses on the bone that disrupt the blood supply to a certain area of the bone. It may be caused by microtrauma, trauma, metabolic, or genetic factors. With the repetition, the osteonecrotic bone can become separated from a feasible bone. This photo is an x-ray of osteochondritis dissecans in a 16-year-old with a 1-year history of knee pain. There is a crescent-shaped area right below that arrow that shows where that lesion is. And the population that's most at risk are boys compared to girls, and it's also more common in adolescents age 11 through 15. Symptoms of osteochondritis dissecans includes knee pain with a gradual onset, knee effusions that can be intermittent, isolated pain and tenderness to the area that it is affecting, pain that's worse with activity, and there can be locking if part of that bone has been separated from the joint. Sometimes the pain is relieved with walking with the foot rotated outwardly. Diagnostic tests include the Wilson's test, which we're going to go over in the next slide, plain radiographs or x-rays, plain films, and sometimes MRI to see that cartilage layer a little bit better or if there needs to be a surgical repair. Management of this includes at least 4 to 6 weeks of immobilization, no high impact activities, and 50% of these heal spontaneously, and some will require surgical intervention. The Wilson's test here, we have the patient sitting with their legs dangling in this case, but you can also have them lying with their hip and knee at 90 degrees. You're going to internally rotate the tibia and slowly extend the knee out. The test is positive if the patient reports pain at nearly full extension or full extension, and the pain's relieved by external rotation of the tibia. Differential diagnoses include meniscus tear, anterior knee pain, and cruciate ligament injuries. Treatment, obviously the goal is healing of the lesion. New bone can replace that osteonecrotic bone if there's a good blood supply there, but the process takes months. Non-surgical treatment is an option if the overlying articular cartilage is intact, and non-surgical treatment is not likely successful after skeletal maturity or the bones have completely grown. Surgical treatment after skeletal maturity or over the age of 12 is typical for these injuries. And surgery is necessary with any loose fragment or an unstable lesion, or if symptoms are persisting after 6 to 12 months of persistent treatment. Education is going to be important, especially if they had a surgical repair, for adverse outcomes of that surgery, including infections, re-injuries, things like that. Consistent immobilization is best for good results. And you obviously want to meet the patient at their specific needs and learning levels and stress the importance of physical therapy. Thank you for listening to this video about osteochondritis dissecans, and I hope you learned as much as I did. Thanks.